Hello, everyone. Happy Heart Month, and welcome to the second webinar in our Heart Month series here at Family Heart Foundation. I'm Aurora Sullivan. I'm a community and care navigator here at the Family Heart Foundation, and I'll be your host for the next hour. So we're looking forward to today's webinar entitled Protecting Yourself from Nutrition to Medication, Managing High LDL and High Lipoprotein A. We have two wonderful guest speakers on our call today, Dr. Seth Baum and registered dietitian Heather Shasa, both of whom I will introduce further shortly. The topic of medication and diet come up quite often in discussions around cholesterol in general, and especially regarding genetic cholesterol conditions such as familial hypercholesterolemia and high Lp(a). So we're very excited to discuss this. Our guest speakers will present on the importance of understanding your cholesterol risk and understanding the steps you can take to protect your heart health. Now, on this next slide, following their presentations, we will also have 25 to 30 minutes of Q&A time to answer any of your questions that may pop up as they're speaking during the webinar today. So please submit your questions under the Q&A feature on the bottom panel of your Zoom frame, and we will get to as many as possible. And so I also want to start with explaining the Family Heart Foundation and the work that we do. We're a nonprofit patient advocacy organization founded in 2011 by our CEO and founder, Catherine Weilman. She's also here with us today. We focus on two genetic cholesterol conditions, familial hypercholesterolemia, or FH, and lipoprotein A, also abbreviated as Lp(a). Both of these conditions are common inherited disorders, with FH occurring about 1 in 250 individuals and lipoprotein A occurring in 1 in 5 individuals. Both of these conditions are also found to be underdiagnosed. FH has an approximate diagnosis rate of 30%, and lipoprotein A only a less than 5% diagnosis rate. So our mission is to save generations of families from heart disease through timely identification and improve care of both FH and elevated Lp(a). We are dedicated to identifying and empowering individuals with these conditions through research, advocacy, and education. You can learn more about the work we do by visiting our website at familyheart.org. And of course, please feel free to connect with us further. We post updates of our research, community work, and educational webinars on all of our social media sites listed here. You can also receive any updates from us directly to your inbox by signing up for our newsletter on our website at the link on the slide as well. And so on our slide here, we have our medical advice disclaimer. This is simply a statement to inform you that the information that we discuss today is not intended to be a substitute for your own personal medical care with your personal medical provider. We're here to provide information on the general topics regarding cholesterol, medication, and diet. However, your individual health plan and recommendations are better left to your own healthcare practitioner. And so I also wanted to briefly touch on this incredible campaign that we were excited to launch on February 3rd called Tackle Cholesterol. We've partnered with former Seattle Seahawks quarterback Matt Hasselbeck to promote the importance of getting screened for cholesterol as early as possible. Heart disease doesn't always come with warning signs. And in our story that Matt has on our page, he tells about losing his dad unexpectedly and how that event prompted the rest of his family to get their cholesterol numbers checked as well. And after being surprised by his high results, Matt was able to learn the importance of getting your LDL cholesterol into the safe zone. So if you're interested in learning more about Matt's story, please visit our webpage to watch his impactful video and learn more about the importance of screening. And discussing screening, it doesn't have to be difficult. With the Family Heart Foundation's Cholesterol Connect program, you can order a kit to be sent directly to your house to be screened in the comfort of your own home. This completely free program allows you to find out your lipid levels by completing a simple finger stick at home and mailing the sample directly to our testing partner. Along with a normal lipid panel, our Cholesterol Connect program also checks lipoprotein A levels, which are not found on your standard lipid panel. Once you've received your results via email, we offer our free care navigation services where you can connect with one of our amazing care navigators for a 45-minute in-depth conversation to discuss your results, your next steps, and to provide you with resources to take charge of your health. Screening kits can be ordered at cholesterolconnect.org or by scanning the QR code on the screen. And so, without further ado, I would like to introduce our first guest for this afternoon, Dr. Seth Baum. Dr. Baum currently serves as the Chief Medical Officer of Flourish Research. With an extensive background in preventive cardiology and clinical lipidology, Dr. Baum has contributed to the field in numerous ways via clinical practice, research publications, and education. Now focused on advancing clinical research processes, it is safe to say that Dr. Baum's expertise is an invaluable presence on the Family Heart Foundation Board of Directors, where he also serves as chairman. Thank you for joining us today, Dr. Baum.
Thanks, Aurora. And it's really wonderful to be here today to talk to everybody about cholesterol and LP little a and cardiovascular risk, diet, nutrition, and medications, and why we all need to be paying attention to this. Um, so I'll start out actually by sort of leveling the playing field, if you will. There are a lot of misconceptions about cholesterol and about LDL and HDL. There's a lot that's not understood about Lp(a) by the general public because the public has not been informed, unfortunately. So that's a different story unto itself. But I'm going to start out with a discussion of LDL and cholesterol. So we've all heard of LDL, and we all have heard of cholesterol. Sometimes we make the mistake of conflating the two. And what I mean by that is cholesterol is a fat, and our blood is aqueous, it's water-based. And fat and water, we all know, don't mix well. If you make salad dressing at home and you shake the salad dressing, you get little tiny bubbles. But these bubbles would not do well in our blood. So our body has very, very smartly fashioned ways to traffic, to transport cholesterol from one place to another. And it does it within what are called lipoprotein particles. They're spherical particles that internally have cholesterol and triglycerides to varying degrees. Now, cholesterol is within a bunch of different particles. You've heard of LDL, which stands for low density lipoprotein particle. There's HDL, high density lipoprotein particle. There's actually VLDL, very low density lipoprotein particle, LP little a. We're going to focus on LDL and Lp today, but the important thing to understand is you've heard people say LDL is the bad cholesterol and HDL is the good cholesterol. Well, cholesterol is cholesterol is cholesterol. There is no bad or good cholesterol. It is the carrier of the cholesterol that's bad. And I emphasize this point because if we look at the human being and the body and look at how LDL moves through the body, the only thing it does in humans is go to the liver so that cholesterol can be removed from the body. It does not go to those tissues like the brain or some of our glands, like the adrenal glands, to make anything. And that's a common misconception. People think, oh, wow, we need LDL. It goes to the brain. The brain needs cholesterol. It is not true. It turns out that every single cell in our body has the capacity to manufacture cholesterol. Every cell. And in fact, in the case of the brain, we have something called the blood-brain barrier that blocks LDL from entering the brain because LDL causes damage. It causes plaque. And LDL and other lipoprotein particles like Lp little a um, tend to interact with our arteries and get underneath the cells and form plaques, which then can rupture and cause heart attacks or strokes or peripheral arterial disease. LDL can do that, LP little a can do that, a couple of other lipoprotein particles or cholesterol carriers can do that as well. So please, whatever we do, do not be under the misapprehension that LDL is good for us. It is not. It does nothing good. In fact, we have data that, and I'll show you a little bit of that in a moment, that reducing LDL to extraordinarily low levels, even absent, does nothing bad in the body and only does good. So let's go to the first slide, having sort of set the stage. So this graph is from a study called Interheart, and it looked at these different risk factors that we call modifiable, meaning we can do something about them, we can modify them. Can't modify genetics at this point, but we can modify these risk factors. And it takes these 9 modifiable risk factors that are attributed to about 90% of the risk for a first heart attack, and it assigns what are called population attributable risks. Meaning, if you remove that risk factor from the equation, so in the case of LDL, if you reduce LDL, what kind of impact would that have on reducing the risk of heart attack? And you can see it is the most important modifiable risk factor to handle. And part of this is because it is so prevalent. So many people have elevated LDLs. And the other part of it is we have a lot of therapeutics that can reduce LDL and have an impact on reducing risk. So we see these other risk factors all important. Smoking, psychosocial stress, hypertension, etc., all important. The most important, LDL, low density lipoprotein. Next slide. So we then say, okay, uh, we know that this is important. Well, let's try to put some numbers. Let's try to attach some numbers to it. So we can look at individuals and say, well, if we know that by reducing LDL by such and such an amount will reduce your risk of what we call cardiovascular events, such as cardiovascular death, stroke, and heart attack. It will reduce your risk by a certain amount. So it turns out that for about every 40 milligrams per deciliter that we reduce LDL, in other words, if we took an LDL of 100 and we reduced it to 60, or 60 down to 20, every 40, we reduce the risk of combined cardiovascular death, heart attack, stroke by about 22%. That is very substantial. If you imagine that individuals who have LDLs of 200, they have how many different 40 milligrams per deciliter that they can reduce it? They have 5 different 40 milligrams per deciliter reduced down to zero, uh, giving each time a 22% reduction in the risk of these very bad events. We've also found that as you get to the bottom, as LDL gets to towards zero, the events continue to diminish and it's absent risk. And we have studies that have looked at literally thousands of patients who've achieved very, very low LDL levels, 20 under 25. And we've looked at their neurocognitive function, um, just to allay the concerns of individuals about the whether or not LDL participates in brain cholesterol, and there is no impact. Neurocognitive function is perfect, even at these very low levels. Again, reinforcing what we know biologically, that LDL does not go to the brain, it does not nourish the brain. The brain cells actually make their own cholesterol and plenty of it. Next slide. So that's really the LDL story, and we can discuss that more in the question and answer period. Now, just briefly on the LP little a. So LP little a, or lipoprotein small a, is actually similar to LDL. It's a lipoprotein particle that carries cholesterol and that causes vascular disease, but it's much smaller and it has a little tail on it, and it is also much more prevalent at a high level. So about 20% of the population has a significantly elevated Lp(a), where we have plenty of therapeutics available to reduce LDL, and where diet can come into play, as you'll learn soon from our wonderful nutritionist. With Lp(a), it's different. Lp(a) is really 90+% genetically determined, really can't be shifted by diet. Is pretty stable throughout life. There are a couple of events or periods in life where there can be significant changes. Um, but what we're going to need for Lp(a) is a medication, actually, and we have a number of different medications in the pipeline, um, and that are currently being evaluated in very, very large studies. And what we see on this graph is that when you go from the low to the high Lp(a), that there's this continuously increasing risk as Lp(a) levels rise. And the risk is substantial. And again, that risk comes in the form of cardiovascular death, stroke, heart attack, peripheral arterial disease, and this has been a major focus of study and innovation, and certainly a major focus of the Family Heart Foundation. We could talk more about that later. The Family Heart Foundation, I want you to know, has published a good deal of literature on this, and we've certainly helped, as in other areas with LDL, we've helped advance the scientific discussion very nicely. So I'll hand this off to Heather now, and then we can answer some questions later. Thank you.
Thank you, Dr. Baum. So I would now like to introduce our next guest speaker, Heather Shasa. Heather is the founder of the nutrition coaching organization Welding Wellness. She is a registered dietitian nutritionist and a clinical lipid specialist. She has 10 years of experience helping individuals manage and reduce cardiovascular risk through evidence-based nutrition solutions and lifestyle strategies. Heather is also a Family Heart Ambassador living with FH, and she has provided her expertise on many of our educational webinars in the past. So we are so delighted to have her here today again. Heather, thank you so much for joining us.
Thank you for having me. So we'll get started, and I am looking forward to talking to you about nutrition's role in protecting yourself and helping to support your heart health in combination to the factors that Dr. Baum was talking about before. So next slide. We're going to dive in a little bit more about nutrition and lifestyle strategies for FH and elevated Lp(a), and talk about some evidence-based approaches to support your cardiovascular risk reduction. So if we look at impact of diet and lifestyle changes on cholesterol levels, there are some impactful changes that we can make. So if we look at LDL-C reduction, we can sometimes achieve a lowering of about 10 to 25%. And that can be through the addition of dietary changes, plant sterols and stanols, soluble fiber, and potentially weight loss if needed. We might even see through lifestyle changes an increase to our HDL through regular exercise, potentially weight loss, and the addition of healthy fats, such as our unsaturated fats, which could lead to a potential increase of 5 to 15%. If we look at a traditional lipid panel, we can also see triglycerides as well, and nutrition and lifestyle modifications can also impact these numbers as well, anywhere between 20 to 50%. So that is through the reducing our added sugars and refined carbohydrates, limiting alcohol, increasing our omega-3s, and potentially weight loss as well, And with lipoprotein little a, there's limited impact for nutrition in terms of actually lowering LP little a, but it doesn't mean that nutrition is not important. In fact, it is, because with nutrition and incorporating modifiable risk factors and controlling for them, that can help to pull all the levers of risk reduction when it comes to atherosclerosis and heart disease. And so when it comes to nutrition and the impact of lifestyle, it can still make a substantial decrease in LDL, but usually with individuals that have familial hypercholesterolemia or have elevated lipoprotein little a, usually medication and other therapeutic modalities are needed in order to help lower our LDL cholesterol levels to the safe zone. So let's talk about foods and nutrients to reduce. So what we know is that there's certain ones in particular that may be beneficial. And when it comes to overall lowering of our LDL and dietary patterns, I want you to think about focusing on more of your overall dietary pattern than one specific nutrient. Okay, so what we want to look at is some of the ones that may influence or potentially negatively impact our LDL cholesterol. So with saturated fat, we want to limit to about approximately 7% or less of calories, and really avoiding our fattier cuts of meat, full fat dairy, butter, and our coconut palm oils, as they tend to be higher in saturated fat. Another thing is trans fat. So we want to avoid that completely. And again, check labels for partially hydrogenated oils. Now, most of these have been reduced or eliminated, but it's still something that we want to be aware of. Dietary cholesterol, we do want to be mindful of. So reducing egg yolks, organ meats, high-fat animal products are also going to help to reduce the amount of saturated fat in our food that can also help to positively impact our LDL cholesterol levels. We want to be aware of our sources of refined carbohydrates. So with refined carbohydrates, what that means is that if we look at a grain, there's three parts of the grain: the germ, the endosperm, and the bran. When they're intact, they're giving you more fiber, more vitamins, and minerals. They're also more slowly digested and absorbed. Refined grains or refined carbohydrates, what happens is you strip off those outer layers of the grain, so it becomes a more quick acting source of energy and might not have as many vitamins and minerals or fiber as in that whole grain. And so where we can also focus here is minimizing more of these carbohydrates, such as white bread, your sugary cereals, or snacks like chips and crackers. We also want to limit added sugars, so limiting to about less than 10% of calories can be helpful. Reducing our sodas, our sweetened beverages, or potentially processed foods with added sugars. And also, again, being mindful of our sodium in our diet. Keeping that to less than, 2,300 milligrams can also be helpful to also make sure that we're maintaining healthy blood pressure levels that are also going to support your heart health overall. And so the key principle here is we want to focus on the food quality, what types of foods that we're choosing, and our overall dietary pattern rather than just single nutrients. So food and nutrients to include are our heart healthy fats, and where can we find those sources, including our nuts and seeds like almonds, walnuts, flax seeds, our fatty fish like salmon, mackerel, sardines, olive oil, avocado oil, avocados. Those are ones that we can add in. Our fiber-rich foods. Fiber is found mostly in our plants, so your fruits and vegetables, whole grains. So examples include oats, barley, beans, lentils. Fruits, all different types of fruits as well, like our berries, apples, citrus. Vegetables, our dark green leafy vegetables, and our cruciferous vegetables, like your broccoli or cauliflower, our whole grains as well. And some special additions that might also be effective in lowering our LDL cholesterol include plant sterols and stanols, sometimes whole food soy protein, dark leafy greens, and garlic and green tea. So what we want to do is aim for about 25 to 38 grams of fiber to really help us to support those healthy cholesterol levels. And also choosing minimally ultra processed foods and choosing more whole foods can also be impactful. And there's some evidence-based dietary patterns that can really help to support overall cardiovascular health and also be supportive for individuals that have FH or elevated lipoprotein little a. The first one is the Mediterranean diet. And so that one is characterized by having high in vegetables, fruits, whole grains, legumes, nuts, olive oil, again, as a primary fat source, moderate fish and poultry, and limited red meat or limited higher fat, particularly saturated fat cuts of meat. Another dietary pattern is a vegetarian and vegan pattern. So this emphasizes whole plant foods such as fruits, vegetables, legumes, whole grains, nuts, and seeds. It's naturally lower in saturated fat and cholesterol, potentially can reduce LDL cholesterol by 15 to 25% compared to our typical Western diet. And also, we want to make sure that we ensure adequate vitamin B12, iron, and omega 3s, especially if following a vegan dietary pattern, as these vitamins and minerals tend to be lower if we're not incorporating a balanced vegetarian or vegan dietary pattern. And the last one is a DASH diet. So DASH stands for Dietary Approaches to Stop Hypertension. And this dietary pattern also emphasizes fiber-rich foods such as your fruits, vegetables, whole grains, as well as your lean proteins. Also limits sodium, saturated fat, and added sugars, supports blood pressure and cholesterol management, and can also be flexible and sustainable long term. So remember, diet is most effective when combined with medication and lifestyle, including regular exercise, adequate sleep, stress management, and smoking cessation. So the overall goal here is that it's not one particular nutrient. It's the quality of what we're choosing and having an overall dietary pattern and lifestyle approach that is going to be health promoting and also help to reduce your LDL cholesterol levels. Thank you.
Thank you, Heather. That was great. So now we're going to enter the Q&A part of the call. We already have a pretty good amount of questions so far, so I'm just going to jump right into it. The first question is for Dr. Baum. I see that we have multiple questions about ezetimibe, so that's the one that I'll start with. Can you give us an overview on what ezetimibe is and its effectiveness on LDL and also ApoB?
Sure. I guess first I'll start with ApoB, what ApoB is. It's a great question. So I mentioned early on that there are certain lipoprotein particles, LDL and Lp being two of them, that cause vascular disease. Well, they happen to have on their surface a very large protein called ApoB, and ApoB is what really determines what's called the atherogenicity of a particle, whether or not it can cause problems, lead to heart attack, stroke, cardiovascular death, peripheral arterial disease. There's one ApoB per every atherogenic lipoprotein particle. And so we can count those and say, well, your ApoB level is at a certain level, you're at risk, even if other levels that we're trying to treat have been reduced. This is going to come into play even with people with familial hypercholesterolemia, because what happens is when we use medications to reduce LDL, which is the primary reason why we're doing this. We want to reduce LDL cholesterol, which is LDL lipoprotein particles. Um, ApoB is reduced less so than the LDL. So you could have some what we call some residual risk if ApoB is still a bit too high. That ApoB can be reduced with the same medications that reduce LDL. So an intensification or an addition of a medicine. Now, we have a variety of different medication types available to treat LDL and ApoB. We know about the statins. That's, the statins have been around the longest since the late 80s. And it's typically the medicines we start with. Ezetimibe or Zetia, which is the trade name, so ezetimibe, is a different kind of agent, works a little differently. It's what's called a cholesterol absorption inhibitor. It blocks the absorption of cholesterol. So interestingly, when we take a statin, the body actually can sometimes increase the absorption in response to the statin, can increase the absorption of cholesterol through the gut. And that's why we use ezetimibe. It blocks that. And the two together, either a statin plus ezetimibe or one of the other agents plus ezetimibe, can be very, very effective at reducing LDL cholesterol and ApoB.
Thank you so much for that. That was very helpful and informative, especially going over the other options since we did have someone ask about other medication options as well. Um, and I do have a question here for Heather as well. How important is it to eat a low steroid diet if you are a hyperabsorber, but not cetosterolemia?
Cytosterolemia.
Yes, thank you.
Yeah, so that's a great question. And again, with cytosterolemia, that is sometimes in addition if you do have, say, FH or potentially elevated LP little a. So it is rare and it really is going to be dependent and individualized to you. So with cytosterolemia or usually one of the mechanisms that can be helpful is ezetimibe and having that medication support. As a hyperabsorber, though, potentially again being aware of foods that tend to be higher in plant sterols and stanols, so not to increase further risk. So working again with a dietitian can really help to support reducing those risk factors and helping you to kind of create a dietary pattern that's going to be supportive of helping understand how to really formulate a pattern that's right for you. So I would say it's really individual based, but really understanding the food sources, ways to lower them, and then also bringing in medication management to help to reduce risk.
Great. Thank you so much, Heather. I do have another question here for Dr. Baum. We had an individual write in regarding their LPA levels. They said that at the time of my heart attack, my LPA was 166. I had it retested a few times. Both show normal LPA at 59 nanomoles per liter. The cardiologist said there's no case study on how they reversed it. So they do take 20 milligrams of atorvastatin, but they're wondering why they need to be on that statin if their LPA is now normal and they're also on a baby aspirin.
So obviously I can't answer a specific question about a specific person, but I can tell you that you started with the person that had a heart attack, right? So if a person has a heart attack, the we always reduce LDL to low levels. So that individual, once you have one heart attack, you're at risk for another. And one of the best ways we know to reduce cardiovascular risk in something called secondary prevention, to prevent the second or third or sometimes even fourth or beyond event, is to very significantly reduce LDL. And we also know that the lower we get the LDL, the lower the risk. Now, LP little a contributes to risk of heart attack, but we don't have I've already said we don't have a medication therapeutic to effectively reduce LP little a and reduce risk. Everything's in clinical trials at this point. So what we do instead is always, even in people who have very, very high LP, always focus on other things, as Heather mentioned. All those other cardiovascular risk factors, diet obviously being important, exercise being important, and of course, LDL being the utmost of importance.
Great. Thank you so much. I have a question now for both of you. The topic of saturated fats has come up quite a few times in the Q&A. So someone is asking if you guys could just comment on the new food pyramid standards that have come out in terms of how much saturated fat they should add to their diet.
Okay, I can start. So with the saturated fat, you're right. With the new dietary guidelines, it can feel a little bit maybe overwhelming and confusing. So the recommendation that the new dietary guidelines came out with is that saturated fat should be less than about 10% of your overall calories. Unfortunately, the new food guide pyramid visual shows foods that might be a little bit higher in saturated fat if you combine them together throughout the day. And so the overarching goal of what we really want to try to do is not just be mindful of the reduction of saturated fat, but also what we're replacing that with. So, what we want to try to focus on with saturated fat is still choosing our leaner sources of protein, being mindful of our full fat dairy versus low fat, right? Keeping that in maybe moderation, but seeing how it affects the individual and seeing how much per looking at as far as saturated fat, keeping those general recommendations and guidelines. So I would say keeping it lower as far as towards the recommendation of more towards the 6 to 7% saturated fat, even less than 10% that might not have elevated LP little a or FH, but still keeping those sources and being mindful of where you're getting those nutrients from.
Yeah, I would just add and build on what Heather said, which I thought was spot on. That we're all individuals. So although we have guidelines in cardiology, we have guidelines in diet. Yeah, everybody has to look at himself and herself as an individual. Saturated fats do increase LDL. If you're somebody who's battling LDL, issues, and you have cardiovascular disease, you don't want to go out and start consuming foods that are very high in saturated fats and potentially worsen your condition. If you're somebody who is sitting around without heart disease and with no cardiovascular risk factors and your LDL baseline is very, very low, you could certainly be more lenient with saturated fat. So everyone's different. And that's why it's great to work with somebody who's an expert like Heather, to be able to understand, how to manipulate your diet to be best for you.
Great. Thank you so much. I think those were very helpful. I know that we've had a lot of questions come up about that. So I knew that it might be a hot topic. And so thank you both so much for those very in-depth answers. One question that I do have for you, Dr. Baum, we have a lot of people ask questions about supplements. So do you recommend any supplements to your patients? I hear some people are on fish oil and the CoQ10 and all of the vitamins and things like that. So just wondering, your thoughts on these.
So I would say that among all of assuming you don't have a deficiency in a vitamin or mineral, right? So assuming you're eating a reasonable diet, I think the one supplement that makes the most sense, frankly, is the omega-3 fatty acids. So then that's EPA and DHA, because we don't have the capacity to manufacture EPA and DHA, and unless we consume it from oily fish, fatty fish, most Americans have very low levels. It's certainly recommended in the early years. So children, as they're going through neural development, that's established. I think Heather in your guidelines, right? So there's a certain amount of DHA specifically because that's really used most by the brain. But so I would say if you're going to take anything, that might be it. The other thing is, there are issues with vitamin D, and there have been many, many studies with vitamin D that have failed to show benefit, although recently there was one that showed benefit, but many that have failed. Most of these studies have are not looking at individual patients' levels and trying to get the patient's levels to a certain point. Again, we can test the levels with your physician. If you're low, then you supplement. By the way, we can also test levels of EP and DHA, the omega-3 fatty acids. So you can also use levels to guide treatment. So I always like to personalize these things.
Thank you for that. For Heather, I've had quite a few questions come in about sterols and stanols. People are wondering the best way to add more to their diet or the best way to just intake it in general. So, do you have any advice for that?
Yeah, so I would say focusing on, so unfortunately, sometimes we don't get enough from our diet per se. The most important thing here is to diversify your plant sources. So diversifying your whole grains, your fruits and vegetables can be impactful. They also do come in supplement form. And so that could be another way to take them as well that potentially can help to lower LDL anywhere I want to say between maybe 5 to 15% potentially. Now, the thing is too, and kind of talking about supplements are not regulated to the same extent that medications are. And so I would always advocate for talking to your physician about the supplements that you are taking because they can either increase or decrease the effectiveness of your medications or other vitamins and minerals. And so having that conversation with your healthcare team and provider is going to be beneficial. And as far as plant sterols and stanols, usually probably having a supplement form may be a best way to take them based on their efficiency. But making sure that it is either third parties tested or again going through rigorous background checks for making sure that they're a streamlined supplement that actually has the appropriate dose in that supplement.
Yeah, I would just
Okay.
add one other thing to that,
Yeah.
which is that the ultimate goal, specifically for LDL reduction, is to reduce the LDL. It turns out that from a risk reduction standpoint, so how significantly I showed that the chart, how you reduce LDL, and there, it translates into a very specific level of risk reduction. How we accomplish that is almost irrelevant. So if you do it through diet or you do it through exercise, you do it through medications, supplements, as long as you do it, you get the same result. The issue, though, from a cardiovascular standpoint, the issue, though, is it's very, very hard to achieve the LDL that would produce the best benefit for you with just diet or just supplements. You can do it with just medications. I'm not saying you should, but you can with just medications. But the reason I think this is important is that the use of medicines, we shouldn't push back on that. We should be open to that. Our medications are very well vetted, and if you do this in, with a good clinician, if you do have a potential side effect, that should be recognized. You should talk to the physician, and then you can always change the medication. The use of sterols and stanols, though, to produce the LDL reducing effect, to me personally, as a clinician, is almost like I don't really see the value just because our therapeutics are so good. Now, some patients say, "Oh, I don't want to use a medicine, please." Okay, fine, then you can try that. But I would certainly recommend that people not get so stuck in the position that medications are bad or evil, that they decline them, because we do have so much data showing the benefits of many of these medicines.
I agree. And to think further context to that, in terms of diet and lifestyle, let's say even it contributed maybe if we were, following all those protocols to a reduction of 30%, if we have even an LDL that's 200, right? That's not going to bring us down alone to an LDL safe zone, into a threshold that's going to lower cardiovascular risk. So, like you were saying, is it's important to have the medication and the therapeutic modality piece working synergistically, because that's going to really help to support that overall risk reduction. And nutrition and lifestyle are all the inputs that we can add in to affect the outputs of lipid levels, of better blood sugar balance, of all of those other things as well. So again, working synergistically, but nutrition and lifestyle alone is unfortunately not going to bring down LDL or elevated LP little a to a safe zone.
And I just add one other thing to that, which is that, um, you know, independent of cardiovascular risk reduction, nutrition, lifestyle, exercise, maintenance of an optimal weight is just the way to go, improving health, reducing the risk of cancers, reducing the risk of arthritis. I mean, there's so many different things that we can benefit from by doing all the stuff Heather's talking about, that it's not just about cardiovascular health and avoiding a heart attack or a stroke.
Yes, thank you both for that. We get so many questions, especially in my care navigation calls that I do, about medications versus supplements. And so having a conversation about both is so important. And so thank you both for weighing in on that. In terms of medications, following along that line, for Dr. Baum, we have someone who asked about LPA therapies that are hopefully going to be coming on the market soon, from clinical trials. When do you see one becoming available, and do you know who will qualify first to receive it?
So we don't know when the first one will be available. We're hoping the first study. These are all what are called cardiovascular outcomes trials. They're very long trials. They're what are called event driven, meaning the a certain number of cardiovascular events have to accumulate before the trial closes. So you never know the precise end date. The first one should be done the end of this year. So I would imagine sometime next year there might be a therapeutic on the market. We don't know what the outcome of the study is going to be. We really, it's all speculation. This particular study was done in what's called secondary prevention. People have already had heart attacks or strokes. So that would be the first population that would probably have access to this particular medication. There are a couple of other studies that are behind this one, and they're closing in. So hopefully over the next few years we'll have some really good therapeutics available. I would add though, there is one treatment that is approved for Lp(a) currently, and that's lipoprotein apheresis. And that's not available everywhere. There are 70 plus centers around the country. It is a technique where we actually, it's almost like a dialysis for lipids, for LDL and Lp(a). It's done every couple of weeks. And it has shown in some studies to be quite effective. Obviously, a more aggressive approach than taking a medication. But just in case anybody in the audience, needs to know that there is a therapeutic available.
Yes, and thank you for that. Um, Apheresis doesn't always come up, especially just with the guidelines around FH and LPA with that. So thank you so much for mentioning that as the approved treatment. For Heather, I did have a question on fasting, or basically kind of blocks between eating throughout the day. Is there any kind of specific benefit to that, or do you have any particular opinions on that?
So if it's in terms of intermittent fasting, there is some mixed results that it might improve potentially lipid levels and inflammatory markers, but again, the evidence is mixed. And so really where it can be potentially helpful is time restricted eating, more so eating within a window because we tend to eat most of our heaviest meals at nighttime. And so if they're more calorically dense, if they're higher calories or higher fat, there might be more of a benefit to having that smaller eating window. However, there is mixed studies, especially for women, that potentially might increase more cortisol levels or hormonal imbalances if it is true intermittent fasting, depending on what that looks like. And so I would say that with it being mixed, if it helps in any way, it could be a tool that you could use. But is it the ideal tool? I would say probably not at this time. I think that there is more research that still needs to be done, but I think that creating an eating pattern that is going to match your lifestyle, your goals, and your needs in a way that you're getting the nutrients in throughout the day that are going to be supportive for your LDL, I think is a great way to go. So yes, can it be used as a tool? Yes. Does it have to be the only tool? No.
Thank you. And then one question for Dr. Baum. We had someone ask about the importance of particle size, and I see this come up a lot, so I would love for you to go over it.
So, the lipoprotein particles that we discussed, specifically LDL, there are bigger LDL particles and there are smaller LDL particles. It turns out that with familial hypercholesterolemia, it tends to be a large particle disorder. So the LDL particles in FH are, before treatment, are large, and they cause harm. There's some misconception out there that large particles are harmless, and that small particles are harmful. Uh, Obviously not true, since familial hypercholesterolemia is a large particle disease, and certainly the increased risk of heart attack, stroke, premature, specifically heart attack and stroke, is very substantial, right? As we take medications, the particles do shrink down. And that was what I was alluding to with the ApoB. One way to keep track of whether or not this has occurred is by monitoring ApoB levels. And that's partly why ApoB doesn't drop to the same extent as LDL or LDL cholesterol specifically. Smaller particles may be on a particle to particle basis worse, more atherogenic than large particles. They may carry more inflammatory products, more oxidized products. Certainly, Lp(a) carries what's called oxidized phospholipids that are very bad, and that's a very, very small particle. So you can make the case that the smaller particles are a little more atherogenic on a particle to particle basis, but the real answer is it's the total number of particles that matters. How many of these you have floating around. More particles floating around, more opportunity to interact with the arterial wall, get underneath the cells, cause a plaque. So that's my answer. And I'm sticking with it.
Thank you. And then one last question for the both of you. One thing that we also have come up a lot is niacin. Do you either of you have comments on niacin in terms of cholesterol and what it can do and suggestions?
So I'll take that first because I used to use a ton of niacin years ago. We used niacin for cholesterol reduction, and it also can reduce Lp(a). And we had an expression, better red than dead. And we used to say that to our patients because with niacin, people got red. They got, they had this burning skin, and it was quite uncomfortable. The problem is that there were a number of side effects that would occur with the niacin, and the effectiveness just was not did not justify the side effect profile. So personally, I moved away from niacin, hadn't haven't prescribed it in many many years.
And I would agree with that as far as again going back to not just single nutrients, right? It's looking at everything in context. And so looking at it as a full system approach. So I agree. I really have it. I promote more so of niacin, which is a B vitamin, how can we nourish and get food sources of that and how we can build better plates and create that balance. So not necessarily adding it into a protocol for practice.
And that is a really important distinction. So the niacin Heather's talking about, very, very low dose. The niacin I
Mhm.
was talking about, pharmaceutical doses. So and that also is one of the issues with nutritional supplements sometimes. Some of the things we get in our diets are great in their very tiny, tiny amounts. And then if we say, oh, look, this is good here, well, let's give 1,000 times that and let's see what happens. You could potentially get in trouble. People can have side effects from anything, even water. Believe it or not, there
Mhm.
are conditions where people drink too much water and they die because their sodium goes down. They dilute their blood. So even water can be, taken in excess quantities can cause harm.
Yeah, absolutely right. It's the dose makes the poison, right? So it really depends on how much that we're using of it. And if it is more concentrated in supplement form, what could it also be interacting with or counterbalancing? So I think that's a good point.
Great. Thank you both so much. That's all that we have time for in terms of Q&A. Anyone who did not have their questions answered, please, reach out to us if it's a really burning question and we will try to get it answered for you. But I'm just going to pull up a couple more slides to close out, just some announcements. So once again, going over our Cholesterol Connect program where you can have that free screening done at home, a lipid panel and lipoprotein A. And then you also get access to our care navigation services, which are also free. So please take advantage of that. And then I also just wanted to mention our LDL Safe Zone campaign. As you just heard from our wonderful speakers, it's important to not only know your cholesterol numbers, but to be proactive in preventing cardiovascular disease through lifestyle and medical intervention when necessary. So we know that cholesterol levels can be hereditary and possibly start to build up disease early in life, leading to early cardiovascular events. So we want people to know their numbers and get into that LDL safe zone. So if you'd like to learn more, please visit ldlsafezone.org. I'd also just like to highlight our Care Navigation Center very quickly. If you have questions about your cholesterol levels, treatment options, specialists, whatever it is, you can connect with our Care Navigation Center for that free 45-minute informational call. And if you enjoyed today's webinar or you're feeling a little charitable this Heart Month, please keep us in mind. You can donate to Help Generations, a family impacted by genetic heart disease by going to familyheart.org/donate. And we would love for you to save the date for our upcoming Global Summit. Our annual Family Heart Global Summit brings together practitioners, patients, and researchers to discuss solutions to reduce the burden of cardiovascular disease in families with those inherited lipid disorders. And Dr. Baum was actually one of our co-hosts at last year's summit in Atlanta. So please keep this upcoming Global Summit on your calendar for October 2nd and 3rd in San Diego this year. And LPA Awareness Day is also coming up. This is every year on March 24th. It is to raise worldwide attention to the impact of elevated LPA. So we run a fun campaign with interactive social media prompts and provide LPA awareness tools as well. So please head to lpaawarenessday.org to learn more about that. And our last slide, please join us for our next webinar in our Heart Month series, Living Successfully with HoFH Today, taking place next Tuesday, February 24th at 7 p.m. Eastern Time. We'll be joined by Dr. Ann Goldberg and HoFH Family Heart Ambassadors, Mashal and Allison, as lived experience guests. And as Vice President and Treasurer of our board, we're also excited to have Allison host the webinar. So to register, please go to familyheart.org/webinars, where the recording of today's webinar will also be available. And thank you so much for joining. Please feel free to reach out with any other questions, but that is all that we have for you today. Thank you.